Emergency cricothyroidotomy is a life-saving procedure used to gain prompt access to an otherwise compromised and inaccessible airway. These icons represent the individual steps for performing a cricothyroidotomy. Pay special attention to them. Take body substance isolation precautions. Prior to the procedure, take and verbalize body substance isolation precautions and put on protective gloves and goggles if available. Verify the need to perform a cricothyroidotomy. The procedure is performed when an upper airway is obstructed and the airway cannot be opened by performing orotracheal intubation or nasotracheal intubation. Additional indications are severe maxillofacial injury or failed needle cricothyroidotomy. Do not attempt to perform the procedure if the patient has tracheal transection. A successful cricothyroidotomy is based on precise location of the cricothyroid membrane and the creation of an incision. What's most important is a timely procedure. Gather equipment. The equipment necessary for this procedure can be found in kits that contain the following: cutting instrument such as a number 10 or 11 blade scalpel, an airway tube such as a Shiley tracheostomy tube, antiseptic, forceps, and hook, a suctioning unit, as well as a blanket. Prepare the patient. Place the patient in a supine position and hyperextend their neck. Note, do not hyperextend the patient's neck if a cervical injury is suspected. Place a blanket under the patient's neck or between the patient's shoulder blades to facilitate the hyperextension. Locate the cricothyroid membrane. In order to locate the cricothyroid membrane, place the index finger of the non-dominant hand on the thyroid cartilage. Palpate the V-notch of the thyroid and then slide the index finger down into the depression below the thyroid cartilage. The cricothyroid membrane is located between the thyroid and cricoid cartilage. Once you locate and palpate the cricothyroid membrane, do not lose its location. If possible, mark the location of the structure with a marker. Clean the area with antiseptic. Before the procedure, disinfect the area with antiseptic. Make a vertical incision. Next, stabilize the larynx with a non-dominant hand, and with a scalpel blade, make a 1.5-inch vertical incision through the skin to the cricothyroid space. Do not cut into the cricothyroid membrane with this incision. Relocate the cricothyroid membrane. Maintain the opening of the skin incision by pulling the skin taut, and relocate the cricothyroid membrane by touch and sight. Make a horizontal incision. Once the membrane is identified, stabilize the larynx with a non-dominant hand and then cut the cricothyroid membrane with a 1/2-inch horizontal incision. Stabilize and dilate the tracheal opening. Insert a cricothyroidotomy hook, if available, through the opening, hook the thyroid cartilage, and lift to stabilize the opening. Next, use the forceps to dilate the opening. Insert the airway tube into the trachea. Carefully insert the end of the airway tube through the opening and toward the lungs. Secure the tube in place by inflating the cuff with the appropriate amount of air. Secure the airway tube in place. Apply a sterile dressing under the tube to protect it and to prevent irritation to the patient. Secure the airway using the provided manufacturer's device. If not available, use tape or cloth ties to secure the tube. Suction the patient's airway as necessary. Insert the suction catheter 4 to 5 inches into the airway tube and apply suction while withdrawing the catheter. Do not suction for more than 10 seconds. Assess the patient for spontaneous respirations. Observe the patient for 10 seconds for air exchange and tube placement. Proper tube insertion minimizes the risk of airway obstruction if the patient spontaneously ventilates. Ventilate the patient as necessary. Direct an assistant to ventilate the patient with a BVM if respirations are either less than 8 or greater than 30. Verify the correct tube placement. Auscultate the patient's chest and check for bilateral breath sounds and rise and fall of the chest. Monitor the patient. Continue to monitor the patient's respirations on a regular basis. Reassess air exchange and tube placement if the patient is moved during transport. Resume rescue breathing if necessary. The most common complications associated with emergency cricothyroidotomy include the following: hemorrhage, which is controlled with direct pressure or the application of a pressure dressing; esophageal perforation, which is a more serious complication and requires surgical repair; and subcutaneous emphysema, which is a complication that does usually not require treatment. However, the patient should be closely monitored for expansion of this complication.